we'll go ahead and get started now. Thank you all for coming. I know it's been, as usual, a busy red day in the hospital. If you guys have any discharge needs, our QB is right here, so please come to her with any discharge needs.
I will swat them away.
As a reminder, please silence your cell phones and pagers for our presenter. I have the pleasure today of introducing our guest speaker today. We have Dr. Asaf Rabinovitz with the Division of Cardiology. He completed his fellowship at Montefiore and has been here since 2014. And works primarily in echo and non-invasive cardiology, and also with interest in valvular disease, non-invasive dynamics, and heart disease and pregnancy. Today, we have the pleasure of having him speak to us on aortic stenosis. So please join me in welcoming Dr. Rabinovitz.
All right, thank you for inviting me. So I figured, as we're having a nice, heart healthy lunch here, so we can talk about a nice. Doesn't count as long as you learn about cardiology, you can do whatever you want. That doesn't matter. Okay, so I kind of deliberated back and forth what to talk about because something that's interesting, that's a little new, that you don't always get from your perspective, but not too detailed or tedious. So I actually was going to talk about TEE, transesophageal echo, uses and pros and cons, and because I feel like that's something that we can educate about, but maybe do it next time. So we'll do aortic stenosis today. Just to it's a huge topic, and there is you guys know a lot about it already, I'm sure, because it's so common. But there's a couple of maybe a couple of nuances I wanted to point out, especially from our perspective in the diagnostic side of things in the echo lab, and also just a couple of highlights in terms of updates in management. Okay, so valvular heart disease is very common, as we all know. Having significant disease is, we see on this graph over 12% of more than 1 in 8 people at the age of 75 significant mitral or aortic valve disease. And aortic valve disease, while not as common as mitral valve disease, is disease of, as you get older, it becomes more common. And as you see, people at 75 years old or older have, at least 3 or 4% have significant aortic stenosis. So it's very common. So we're just going to touch on a couple of things, etiologies of aortic stenosis, just the basic pathophysiology, nothing going to be too earth-shattering there. And I'm going to give you a little bit more flavor of the echocardiographic principles that we use in terms of assessing it, and when and how do we replace it. How do we replace the aortic valve when it needs to be replaced? Okay, so back to the real basics. So we are going to talk about the aortic valve. So obviously you have your blue blood coming back into your right ventricle, into your right atrium, to the tricuspid, to the right ventricle, to the lungs, gets oxygenated, comes back through your left atrium, through the mitral valve, into your left ventricle, and then it gets pumped out by the left ventricle into the aorta, to the systemic circulation. Okay, so we have the left ventricle. Just don't think the things I want you to keep in mind. You have your left ventricle, and then you have this region just before the valve, where it's kind of the tubular, where it becomes a little tubular, leading up to the valve and injection of blood. It's called the LVOT, left ventricular outflow tract, and then you have the valve apparatus itself in the aorta. So we'll keep that in mind as we look at some pictures later. Okay, so in terms of common cause of aortic stenosis, the most common cause is senile degenerative calcific aortic stenosis. That is basically just a disease of aging. So we see that as very rarely do we see it in younger people. It's more a disease of people that are 75 years old and older. It happens to have the same risk factors as coronary disease. So smoking, hypertension, hyperlipidemia. But again, you see them with and without these risk factors. You see them some familial patterns sometimes, but it's mostly the biggest risk factor is obviously age. So we also have on the spectrum, what precedes aortic stenosis is what's called aortic sclerosis. That's just a splotchy calcification of the valve, which doesn't really affect the leaflet opening or has no hemodynamic significance. But it's significant in that it is the beginning of that spectrum. So that is the first sign that things could progress to aortic stenosis sometime down the road. Because that's not something to just, totally ignore. It's, you want to know if that somebody has calcification on his valve. his or her valve. So that's calcific AS. We're going to talk about most of the talk. The other common cause of aortic stenosis is congenital aortic stenosis, which most commonly is a bicuspid aortic valve. So normal aortic valve has three cusps, the right, the left, and the non-coronary, based on the coronaries that come out of there, the regions of the aortic valve. So bicuspid aortic valve has only two cusps, or usually more commonly three cusps, but two are fused. So it functionally behaves there are two cusps. And there's something in the makeup of the tissue that causes it to become calcified and degenerate much earlier. So on average, 2 decades earlier than normal valves. We're talking about people that are in their 50s and 60s. And it's relatively common, 1 to 2% in the population. And it's not just the valve that's involved, it's the entire systemic vasculature, or at least the aortic part of the systemic vasculature. So commonly you see involvement of the aortic root, of the aorta in different forms. So that's also important to keep in mind. And then you have the more rare ones, rheumatic aortic stenosis. That we don't see very often. If you have rheumatic mitral disease, then you sometimes can have aortic disease. Not that common, so we don't really talk about that much. Okay, so what happens with aortic stenosis? So the pathophysiology is not, it's pretty straightforward. You basically have a mechanical obstruction, right? So blood's supposed to flow through the aortic valve degenerates, whatever the reason, because of overuse, genetics, hemodynamics, whatever it is, but the valve starts to wear down, the doorway gets creaky, the hinges get hard, and the ventricle starts to see this pressure, right? So it's got to now pump blood through a narrow orifice. That's more work for the ventricle. That's called the afterload. So the afterload of the ventricle is what force, what pressure, what parameters that the left ventricle sees when it has to pump out the blood, eject the blood from the heart. So it sees the aortic valve orifice, it sees the systemic blood pressure. So all those things put together make up a concept called the afterload. So when your aortic valve is narrowed or it's not opening well, you have an increased afterload, and the ventricle feels that. And initially, the ventricle compensates for that by hypertrophying, right? Because the equation for stress, to reduce stress, thickness is in the denominator. So the higher the thickness, then the less stress there is in the cavity. So that's the compensatory measure of the LV becomes hypertrophied. But over time, the tissue so then you have LVH, so the tissue becomes stiffer, it can't relax well, the LV can't feel well, and eventually the LV starts to fall apart, and you get the ejection fraction starts to fall. So that is the pathophysiology. Now, this is a super important slide, a super important curve that I'm sure you've all seen, that aortic stenosis in its latent period is super well tolerated, and the prognosis is pretty decent until it becomes severe, until it becomes symptomatic. Once it becomes symptomatic, which is at that curve here, the prognosis falls off a cliff. Okay, so it's really critical to diagnose and find this point. If you have a patient, you want to make sure, are they symptomatic, because that changes the entire way you approach how to manage. So once symptoms develop, that second bullet point, the risk of death increased from 1% per year, which is tolerable for somebody who's let's just say 75 and older, to 2% per month. So really super poor prognosis. And if you don't intervene, then 3 years, 75% mortality at 3 years, and a high incidence of sudden death. So really, we're okay as long as they're on that latent part of that flat part of the curve, but we don't want to miss when the curve starts to head south. Okay, that is super important in terms of our management, and it's often in the primary care and the internal medicine practice that point is found, and then the referral to more specialized care is warranted. So you saw in the previous, so there's that little blow up. There are 3 particular symptoms that are associated with aortic stenosis, the triad of aortic stenosis. So that's syncope, angina, and heart failure. So syncope is the least common, and the reason it happens because you have an LV that's trying to compensate for a decrease in peripheral vascular resistance. So usually when that happens, when your systemic vascular resistance goes down, the way to compensate and to increase your blood, cardiac, to maintain the blood pressure, to increase cardiac output, to increase the blood being ejected, and the LV can't do that because there's a stenotic aortic valve. So that's an alarm finding. Angina is also an alarm finding that could be because of high pressures in the LV, demand supply mismatch, and then heart failure symptoms, whether it's diastolic heart failure or systolic heart failure. So all those things you got to be on the lookout for in terms of your aortic stenosis management. Just a brief word about physical exam findings. So we know this: you have your late peaking systolic ejection murmur at the right upper sternal border. You have your delayed carotid upstroke, and then your absent component second heart sound. So again, it's nice to read that a book. They're pretty. I mean, the murmur is easy to hear. The others are a little bit more subtle, unless you have experience in these conditions. So all these things put together are very useful in your management. So how do we diagnose? So this is what we're going to spend a little more time on. Is echocardiography. So echocardiography is basically the bread and butter of aortic stenosis. It gives us almost everything we need. We can look at the valve, how the valve looks like. We can look at the leaflets, how they're moving, how they're looking. We can assess stenosis. You have all these amazing hemodynamic measurements. We can look at the left ventricle, if there's been any changes in the LV because of the aortic stenosis. We can look at the rest of the heart, if there's any other concurrent lesions. So in the old days, it used to be a cath diagnosis, aortic stenosis. Not anymore. Now it's not recommended unless you really have trouble with your diagnosis. So how do we do that on echocardiogram? So in the old days, so let's go back. In the old days, so I put down this picture on top right just for reference. They didn't have this picture on top, this kind of image. So just to orient you, this is a picture taken from the middle of the chest. It's called the parasternal view. And you have your right ventricle up here. We're not going to talk about that today. This is your left ventricle, and you have your mitral valve here, and your aortic valve here. So blood is coming from your left atrium into the LV and being ejected this way. Okay, so that's like a normal, one of our normal views. You can see a nice view of the aortic valve. So in the old days, they had what's called M mode, to adjust a Doppler ultrasound, but just of one plane. See this line over here? They can put this one line and look at the tissues in just this over time that this line intersects. Okay, so and you can see in a normal aortic valve, you put the line right across these aortic leaflets, being right over here, right? And you can see that in systole, here's your EKG. In systole, you have your leaflets that are opening, right? You get this space, and then diastole, they close, open and close. Okay, so you can see that just in that one little plane. And then in aortic stenosis, what you get in that same M mode assessment is you don't see the valve open, right? The leaflets. That's how they used to do it in the old days. They have no pictures, just a 1D assessment. Now, move forward. We have 2D imaging, which is the image I showed you before. So you can see a whole field, a two-dimensional field of your heart, right? So that opens the doors. Now we can look at the aortic valve. We can actually see it in real time how it looks in different planes. So you can look at it in this long axis plane, right? You can see at least how they open. Compare the normal to a aortic stenosis case, right? Rocky, calcified leaflets that you can barely see opening. But you can also turn the probe and look at it like a slice of bread, slice across the valve, right? So you can see beautifully 3 doors, right? 3 tri-leaflet valve, 1 leaflet, 2, and 3, as opposed to a aortic stenosis case where you cannot see the valve leaflets at all. They're super calcified, barely opening. So that's good. So that means it's qualitative. You can say, okay, this one looks good, that one looks really bad. It's more like a yes, black and white assessment. What it did open the door for initially is we can maybe look at the orifice and measure the orifice. So you look at the valve, how at its most open state, and let's measure that little hole between the leaflets. That'll be our aortic valve area. So that, in theory, is good, but it is super tough because these valves are super calcified. The leaflets open in a very asymmetric way. So it turns out this is not a very accurate way to assess aortic stenosis. We use it if we're really stuck. Sometimes it's helpful. Something you can see this view on a transesophageal echo better, but we generally don't use this. This is already dropped down in the hierarchy of recommendations how to assess aortic stenosis. But that's what 2D imaging gives you. You can look at the valve. You can also look at the, like we said, the valve morphology. So on the top right is a normal tri-leaflet valve. And these videos are kind of each going their own little speed. I don't know why. But you have a tri-leaflet valve, it's a normal. But then we can look at, is a valve morphology normal. So on the left, you have what we just spoke about is a bicuspid valve. You can appreciate you have two cusps here that are fused right here. And it opens up in the shape of like an oval, like a football. Right? So this is a bicuspid valve. So this is one that it's not stenotic. You see that leaflet are opening, but it's at risk to develop early aortic stenosis. Then you have the more rare congenital types like quadricuspid, like four cusps, and unicuspid, but those we never see. So 2D gives you qualitative assessment of the leaflets and valve morphology. But that's not enough. So what echo really changed is when we be able to apply the Doppler principle. So don't worry about all the fancy equations and all the fancy words. Basically what Doppler allows you to do, and we've all experienced this, is that it allows you to send the ultrasound beam on the ultrasound and not only look at the tissue and the structures, but to assess the velocity and the direction in which they're going. Okay, so you shoot that ultrasound beam from your transducer, and it hits blood going away from you, so it sends you a certain signal and also gives you the velocity of that blood, or vice versa. You know if it's going away from you or towards you, and you know at what velocity it's going. So that already that's the game changer. So without that, echo would be a very little boring field. Just getting a bunch of pictures, and you can't ultrasound, you can't really tell so much. But now we can assess velocity. So that opens the door to major hemodynamic assessments. We can measure volumes of flow, we can measure pressures. So that is where the field takes off. So let me give you a couple examples of what we do very, very basically. So this is what we see when we take a Doppler of blood flow. So on the x-axis is the time, and this is the velocity. So this is one beat. So on this particular beat, we see peak velocity, and we can use this to measure. We see how fast the blood is flowing, and we can turn that into a volume that is ejected. And how we do that is we look at the area through which the blood is flowing, and we can figure out the volume that flows through the blood just with getting these Dopplers. So for example, here's your heart, right? Here's your aortic valve. Here's your, like we said, the LVOT, right? So if I can figure out the area of the LVOT and using this spectral Doppler, I can figure out the stroke volume. So I can figure this just without invasive, no invasive procedures. We can figure out how much flow, how much volume, how much blood is being ejected every beat, every cardiac cycle. We need two things. We need the Doppler signal, which is easy to get, and we need the area through which the blood is flowing. Okay? So what do we do with that? So we have something called the conservation of flow. So there's a tube of different diameters, and the same amount of blood is flowing through the whole system. So the flow through one point is going to be the flow through the other point, right? And this leads us to what's called the continuity equation. So flow through the LVOT, which is right before the valve, equals the flow right through the valve. We can use that to calculate an aortic valve area. So flow through one is the flow through the other, and then we can plug in the numbers and figure out an aortic valve area, that's the numbers we use to assess the severity of aortic stenosis. So Doppler allows us to do that, which is one major aspect of the assessment. And the other one, when you know the velocity, as something speeds up, the pressure gradient goes up. So they're directly proportional. So if there's a high velocity between the left ventricle and the aorta, we know the gradient is high. So we just take the velocity, let's say it's 4 meters per second, and plug that into what's called the Bernoulli's equation. Then you get 4 times v squared, or 4 times 4 squared. you have greater than 64. Okay? So for example, the tech gives us this image, right? So if you look, your probe is on the top of the picture, the interrogation goes through the aortic valve, and the Doppler gives you this. This is the signal, and we just trace the beat, and we get, and the computer gives us all these measurements. And we need, for our purposes, you have your maximal velocity, so 4.6 meters per second, which is super high, and your mean gradient, which is 50. So these are numbers we translate into severity of aortic stenosis. So for example, and how do we get from there to valve area? We take the continuity equation, plug in some numbers, right? We figure out the area of the LVOT, the flow to the LVOT, the flow to the aortic valve, and we get the aortic valve area. So that's what we do in terms of assessing your aortic stenosis patients, right? So we have three major parameters. These are all the class 1 parameters. When we give a report, this is what you have to report. You have to report your area, your velocity, peak velocity, and your mean gradient. Okay? So 3 parameters. And the critical numbers to know, you have to know what's severe, what's not severe. The numbers on top are less important. But a mean gradient of 40, a velocity of 4 meters per second, area of less than 1. Okay? So you have those, you have severe aortic stenosis by the textbook. So, and what do we do with these numbers? So once we have a severe aortic stenosis, right, how do we know when we need to do something for this patient? So this is from the valve guidelines. And the number one thing with severe aortic stenosis is symptoms. So if you have, like we saw that curve before, once you have severe aortic stenosis and symptoms, you need your valve replaced in a timely fashion. Okay, so that's the simplest one. Always inquire about symptoms. The other important indications are if your LV is taking a hit, right? The ejection factor is already taken a hit. It's already below 50%. So those are all, or you're also going for other heart surgery. So all those are class 1 indications to replace the aortic valve. Again, you have to be severe and either symptomatic or those other ones if you're asymptomatic. Okay, so that is pretty straightforward. You get your echo report, you have numbers that meet severe, you have a patient who says I have chest pain or legs or signs of heart failure. You check your echo report, mean gradient is 45, your velocity across the valve is 4.5 meters per second, your area is 0.7, piece of cake. Right? So that is AS 101. But AS, it gets tougher because sometimes you have cases are not straightforward. What if you have the guy who has those bad numbers on paper, but he's 75, he's playing tennis, and he's swimming 3 times a week, and he rides his bike every day, and you're like, your numbers look horrible on paper. So what do we do with asymptomatic severe? This is a struggle. You can even see on these guidelines, right? I'm going to talk about. We're trying to figure out what to do with these guys. We're kind of uncomfortable leaving them alone, just saying, okay, we'll see you in 6 months or in a year, right? So on the one hand, their prognosis is not bad. Sudden cardiac death is 1% per year if you're truly asymptomatic. But most people don't remain asymptomatic for very long, so you're afraid to kind of miss the key point. So what do we do? Is there any clues we can use to find the patients who are at higher risk? So none of these are slam dunk. So, the different groups that are proponents of different parameters. So, for example, let's say you're super severe, terrible numbers. Velocity is not 4 meters per second; it's 5 meters per second. It's through the roof. When you mean gradient, it's not over 40; it's over 60. So, if it's a critical, really severe numbers, then some would say even though they're asymptomatic, you should replace. What are the diseases progressing fast? Another parameter that may be useful. And then there are other ones that have been proposed, but not verified or validated to make them really strong indications, like elevated BNP. We're going to come back to stress testing, or your LV is being hypertrophied, or you have some other type of signals of abnormal LV function. So asymptomatic is tough. One thing is that in the old days, we used to be afraid to stress these people, put them on a treadmill and see how their heart responds. and their blood pressure responds. Now that's not true anymore. We consider it pretty safe now as long as they are being monitored. And if you can elicit, symptoms, angina, pre-syncope, shortness of breath, excessive dyspnea, very poor exercise, then you've helped yourself. I mean, a lot of times the patient can't do very much, so their whole asymptomatic is their really adaptation to their limitation of the aortic stenosis. They think they're asymptomatic. When you objectively measure them, they cannot do what you'd expect them to do. So they really are symptomatic, and then that's enough to intervene. The other thing is you see how they respond to hemodynamic is. Their blood pressure failed to rise. In normal stress, your blood pressure is supposed to rise when you exercise. For them, either it can stay flat or it can drop. That's also a concerning sign. So this is another tool that if you have an asymptomatic patient that is stressed, now it's being commonly used. You see if it's positive or negative, you can really make a big difference between in terms of the patient's management. So what do you do with but the guy, everything's negative. Do you say, see you next year? See you in 5 years? So if you have asymptomatic aortic stenosis, if it's severe, the answer is you got to see them often. And you got to echo them pretty often. Because, again, that curve, remember that curve, if you miss that point, you're on a cliff. So that's going to drop real fast. So if you have look at that bottom line, severe aortic stenosis, you should see them every 6 to 12 months. They should be echoed because you want to make sure the LV is still okay, the numbers aren't getting much worse. So very close, very far. You don't want to miss their when they're developing symptoms. The other challenging case I was going to bring up, you've probably seen this on reports, is that what happens if your parameters are discordant. So this is all nice when all those numbers across the bottom point in one direction, to severe or not severe, right? Problem is, often, I would say too often, probably more than half the time, is we get this problem. Your gradients and your velocity are not in the severe range, but your area calculates to into the severe range, below 1. So what do you do with that? Do you go by the area, and it's severe because it's less than 1? Or do you go by the gradient, the mean gradient of the velocity that's not in the severe range? So usually this happens in patients that have low ejection fraction. So the question is, when we have a low area in the valve, does that mean because the valve is really, cannot open anymore? Or is it because the left ventricle is so bad, it just can't pump out enough blood, it's going to open the valve more than that's all the valve needs to open, because that's all the flow that's going through the valve. Had the ventricle been better, maybe the valve would open more. But for this amount of cardiac output, the orifice needs to be very small. So how do we distinguish between having a valve that is the problem and the ventricle is weak because the valve is too tight, or it's because the ventricle, or is the valve okay? The ventricle is the issue, and because the output from the ventricle is so low, that's why the valve looks like it's opening minimally. So that's what we try to distinguish. That's what we sometimes recommend what's called debutamine stress echo. And just to simplify, is that debutamine stress echo is an inotrope. The debutamine is an inotrope. So we're just trying to kind of fuel the ventricle, give it a little more oomph, a little more pumping, right? To increase that output and see what happens to the valve. So sometimes you give the debutamine, the valve area, and you measure it under a high dose of debutamine. Then the valve area, if you do all your measurements, the valve becomes 1.2, 1.1, 1.3. It goes way up, and your gradient stays in the low range. As opposed to if it's really a problem with the valve, then as your contractility goes up, the gradient through the valves go up, but the area stays below 1. So that's true severe. So we can try to distinguish in true severe aortic stenosis, where the velocity increases, but the area remains low, so it's really severe. Or you have what's called pseudo-severe. It looked like it was severe, but really it's not a valve problem, it's a problem with the ventricle. And just more output from the ventricle will increase the aortic valve area to above 1. So sometimes you're going to see on your reports, you recommend debutamine echo. And that's why I focus. We have a discordance with the numbers. We have a low gradient. We have a very low valve area. So that is what we try. Those are two most common kind of aortic stenosis challenges. Asymptomatic, yes, how to manage, and we have discordant findings. So I found out just one tip for reading an echo report. So, the way our echo reports are formulated, we have like the summary page in the front, and then if you dare, you turn the page and go to the next page with all the numbers and all these findings, a ton of findings and numbers. So we just throw in the front, severe, yes, moderate, yes. And that's all that goes there, which is really not fair. We're actually upgrading the system. There's going to be much more information on the front page because it's not just that, right? You should really look at the numbers. The numbers make a difference. Not all severes, something that's severe is not really severe. And something when it's severe, not all severe are created equal, okay? One thing I'll tell you for sure is it's not just the aortic valve area. That used to be the case. The field is moving away from that. Aortic valve area is a calculated number based on measurements that we often cannot make accurately. So aortic valve area, I would say in the hierarchy of your mean gradient, peak velocity of area, it's a distant third to the velocity and the mean gradient. Okay, so turn the page and look. They said severe. So what does that mean? So if all the numbers point to severe, everything is concordant. Okay, you're good to go. But often you're going to have this. So you're like, they call it severe, but I see a mean gradient of 32, right? Or a peak velocity of 3.6. So why are they calling it severe? The aortic valve area is often, less than 1. So it's more complicated than just going by the aortic valve area. So what do you do? So like I said, it depends on the flow, depends on the EF. So the report should give you that. And if it doesn't, it warrants it's reasonable to ask from why is it not severe? Why do you call it severe if I see the gradient is too low? They should tell you it's low flow or normal flow or the EF, and they recommend more testing. So that's all very important. The other thing I wanted to point out is that the real critical number for aortic stenosis is 0.8. It's not 1. Okay, so if you look at what corresponds to a mean gradient of 40, it's an area of 0.8 or below, not 1. 0.8 to 1 is kind of the region where we think intervention is going to help if that is the problem. Okay? 0.8, if it's below 0.8, then you can confidently say, I think this is severe aortic stenosis. Even if the numbers otherwise don't match. But if it's 0.9, 0.95, so our system, less than 1, it just auto-populates severe. It goes to front base. But that's not necessarily true. So the other parameters are very important. So really the 0.8 is the number that's critical, that's really severe aortic stenosis. If it's between 0.8 and 1, then again, we're less confident. The last thing is, your 95-year-old lady with a BSA of 1.3 is not like you're a football player with BSA of 2.2. So different, the areas, the aortic area is not the same. We index it, so let's always look at if there are significant different changes in the body size for the patient could play a factor in what's considered normal aortic valve area. Okay, so that's basically, yeah, please.
So what's the rationale for getting the non-CT?
So I put it in the smallest font that I thought we could read, because that's open. I don't want to open it. So we spoke about low that when the discordance, when you have low gradient, but so not severe, but a low area, which is in the severe range. So usually that's when the ejection fraction is bad, and the ventricle doesn't pump enough blood through, and so you go through your whole Dubini echo algorithm. Problem is sometimes you have that same discordance, but your ejection fraction is normal. So you're like, wait, if the ejection fraction is normal, why is there discordant in the findings, right? So that algorithm is a little more complicated. We don't really know what to do about that. Often it's old ladies with hypertrophied left ventricles, that there's just it doesn't hold a lot of blood, so your flow through the aortic valve is low. So this is a challenging diagnosis if the EF is normal and you have those discordant findings. If your EF is low, then you do the Bunami echo and you go through, that usually often answers the issue. So one of the commonly things we do for that is to get a non-contrast CT to help with the degree of calcification of the valve. We don't have great answers. It's one of the ones that's commonly accepted. If the super calcified valve, so you can assume it's really severe aortic stenosis. But we don't know what to do. Do we put them on a treadmill? Do we try to make them hypotensive? So I'm not sure. That's why I don't want to get into. It's a whole different kind of can of worms. We could do, we could talk about it next time or a different time. But it's a little more than I would want to get into right now. So that's why it's a kind of a diagnostic dilemma. When the EF is normal, when you still have those discordants. Okay, so just let's talk the last 10 minutes on management. So what's good about aortic stenosis is that it's nice and simple to manage, right? Once you cross your threshold, the solution is surgical referral. There's nothing, pretty much very little else we can do. It is a mechanical problem. Meds have been tried. Nothing shows. But if statins don't help, then nothing helps. So no drug has been shown to alter the course of disease. But I mean, you can't ignore the other comorbidities. You still have to treat, right? Especially hypertension. So hypertension. Remember, because the LV. Again, what the LV sees is a combination of the valve problem and what's beyond the valve. So if you have, your patient's running at blood pressure 180, that's not making life easier for the ventricle. It's making life harder for the ventricle. So hypertension should be treated. Truth is, you look around, there's not that many recommendations how to treat, how to particularly treat the hypertension if people have severe aortic stenosis. They say start slow because, again, if you go too low, it's hard for the ventricle to compensate. If you go too low, to generate a cardiac output to maintain the blood pressure. Some people say don't use vasodilators, don't use diuretics. But the truth is, there's nothing hard that is recommended. But I think going slow and safely that's reasonable. We have a procedure called the balloon valvuloplasty. That they basically stick a balloon and they just inflate it and crack the valve open. And that used to be, used, but we consider it pretty much not even treatment for aortic stenosis because no mortality improvement. The any benefit, which is usually minimal, does not sustain even up to 6 months. It can cause aortic regurgitation if you just crack the valve the wrong way. So this is truly just a palliative procedure, if nothing else is an option. We'll talk about the options in a second. Sometimes it's useful to bridge you, to get you to your valve replacement. So you have, you're patient with aortic stenosis, you want to do surgery or a TAVR, but they have a GI bleed. So they can't give the medicines after, so you're kind of stuck in sometimes rarely we use it as a valvular, just to get them through, to fix another problem, the GI bleed or whatever, and then we'll come back and definitive treatment of the valve. But it's really just either to buy you some time or palliative. Okay, so that's really we not consider that an option in our algorithms. So the only thing that works is aortic valve replacement. And what's amazing about aortic valve replacement is these patients are so sick, and with nothing, they're on this curve. You fix the valve, you replace the valve, and they have super unbelievable. They do well, like basically a normal life expectancy. Again, we're talking about older patients, often with comorbidities, but from the valve standpoint, their life expectancy and their survival is just unbelievable. So look at that, over 80% at 15 years. Again, we're talking about old patients. So, and the more symptomatic they were, the better they do. And you can see these curves are just so divergent. So that is the long, traditional, definitive, time-tested therapy, right? And it's very safe. So if you look at this graph over here, this is patients, we'll get back to this in a second, but you see patients that are normal surgical risk, they're 1 to 2%, mortality. So that is pretty good. If you're 80, 85 and you're old, 30 days, it's less than 5%. So that's a really good remember, we're cutting the chest. We're talking invasive, serious cardiothoracic surgery, and the mortality is so low. We got very good at it. Now we put in mostly bioprosthetic valve because they've gotten better. They're older patients that we don't need the valves to last 40 years, right? 30, 40 years. And our bioprosthetic valve now lasts 15 years, so they get most of our prosthetic valves. But this statistic is so troubling, right? Let's say half. Only half of the patients that meet all those criteria we just spoke about actually get surgery. And the question is why? And the answer is obvious, because either they don't want to deal with it, like whatever, we can't deal with it at my age and my situation, or the doctors think they're too high surgical risk. They're all old. 95% are very old. Comorbidities, sometimes significant, with renal disease and strokes and liver disease, and they're frail, right? So the surgeon looks and says, doesn't pass the eyeball test. And the cardiologist, sometimes they don't get to the surgery. The cardiologist says it doesn't pass the eyeball test. So while surgical aortic replacement is a great treatment, only half people that should be getting it are getting it. So what are we going to do about that? So there's a couple of things. So you might have heard this term STS score. So this is a calculator that the interventional cardiologists and the cardiothoracic surgeons use to assess risk of cardiothoracic surgery, right? So you punch in a ton of parameters, and it spits out your risk of mortality, length, 30-day mortality, risk of renal failure, blah, 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 blah. And using this is what we mostly use here, and using that score is how we stratify risk, okay? So these numbers are important to know. So anything less than 4%, we consider that a low risk, right? And the surgeons will take them. Median risk is 4 to 8%. Anything 8 to 15 or higher is high risk. And then you have, the ones that are super high risk. Okay? So, because these patients are high surgical risk, a lot of patients, and that's where they've been turned down for a surgical aortic valve replacement, we now have, it's already now in standard everywhere, is not surgical aortic replacement, but transcatheter aortic valve replacement. Right, so we put in a new valve through using catheter. No sternotomies, now it's not even general anesthesia. It's done under local. It's just done under moderate sedation. So really, much less invasive way to replace the valve. Right, and we have two valves that we use. There's the Edwards Sapien valve, and this valve, you put it right in the aortic position, and you balloon it, and then you inflate a balloon inside it. It's called a balloon expandable valve, and it kind of pushes all the calcium and leaflets out of the way, and it sits there in the aortic annulus. Or you have the core valve, which is a self-expanding valve. You basically drop it off, you release, and it slowly dilates into position. Okay, so these are the two things we can put an aortic valve in the aortic position. Now, there's a lot. I could talk about 20 trials, but we'll talk about one because that is absolutely a landmark, a field-changing trial, the partner trial. So they looked at different groups, and they worked their way from the sickest group, which is the people that could not have surgery, right? And they worked their way up. So in partner trial cohort B, so it's TAVR for aortic stenosis in patients who cannot undergo surgery. The surgeon looked at them and said, sorry, too sick for surgery. Forget the score, forget all these calculators, too sick, too frail, too much COPD, home oxygen, bedbound, they cannot tolerate surgery. So they looked at those patients and they said, let's put a TAVR in them and compare that to standard therapy, which is basically nothing. Medicine, treat the hypertension. There's no therapy, standard therapy for aortic stenosis. And they did unbelievably better. Their survival was, 20% survival improvement at 2 years or whatever. It's 25%, some unbelievable number. Cohort A, they just, let's not work with the inoperable patients. Let's talk about the high-risk patients. Patients who the surgeon would take, but they're high risk for surgery. And there, the goal is different, right? The goal is not to be better, just as good. As long as you're just as good as surgery, then this should be a reasonable alternative. And they showed that transcatheter does not do worse than surgery. So these are the first ones that came out. And the only thing I would comment, they did have, vascular complications, they did have more strokes than in surgery. And then the next one that comes out is let's work our way back on our risk spectrum. Now let's compare transcatheter aortic valve to patients who are intermediate surgical risk. And this is from 2 years ago. And again, they showed that there is no difference, just as good. And not only that, if you look at all the little, if you read the paper and all the numbers, stroke incidence went down, vascular complications went down. As the devices got better, as the operators got more experience, all the complications of TAVR came down to where they're not different than surgery. So we have an alternative, right, which is just as effective and just as safe. So now that's intermediate patients. And now in next week or next month, in the ACC, they're going to release the results of the partner trial, which we already know is going to be a non-inferior. Then compare low-risk patients. So basically, everybody is going to be a candidate for TAVR. So you have this amazing intervention, surgical aortic valve replacement, which is stood the test of time, but it's going to become obsolete because everybody's going to have, no matter your surgical risk, you're going to have a transcatheter, you're going to have your valve placed percutaneously. So that's important and exciting. It's not, so your candidates are people that are like advanced age, if they have comorbidities, renal, lung, liver disease, or anatomical factors that would complicate surgery. So we would lean towards TAVR. But it doesn't come without its limitations. Paravalvular leak, so you don't always get a great seal, and that's important. You get too much aortic regurgitation. Permanent pacemaker, especially those self-expanding valves, you get a very, very high rate of needing a permanent pacemaker because it interferes with the conduction system. And strokes, early on, there were very high numbers. Now they're getting better, so that is becoming less of a problem. This is I think my last slide. The last thing I'm going to say is that it's not like the answer. You don't get this, this horribly sick person throw a percutaneous aortic valve and say, okay, you're good to go, clean bill of health. So if they have life expectancy less than 1 year, then it's not recommended. And also they showed in the trials that if your your score was super high, even in that case, TAVR was not better than. So these is all patients with medical therapy versus TAVR. You've seen the patient that is super, super sick, super complicated. Even TAVR doesn't make a big difference. So it's not, it's not everybody gets. You got to use you got to be intellectually honest and see, do we think this is going to help this patient? So this is my last slide. So this is constantly changing. This algorithm. So it started with class 1 for prohibitive surgical risk. They're not surgical candidates, and this was a class 2. And now this became a class 1, and intermediate risk became it. And by the next year or so, they're going to be all class 1s for anybody of any needs of aortic valve replacement, of any age, of any risk. The answer is do percutaneously. You go home the next day, even sometimes the same day. It's not really the same day sometimes. It's going to be the same day. It's going to be like putting in a stent like it's nothing. So that field is certainly growing. And also it's going to be growing in terms of you put in other patients. Let's see, some patients, like those one you talked about, maybe for asymptomatic patients, to throw a valve in there is so easy. Let's just do it, right? So it's going to open up the field to intervene in patients that we were a little afraid to intervene in the past. So a lot more to come from what is the indications for percutaneous aortic valve replacement. That's it for today. Any questions? I'm happy to answer any questions. Yeah, hi.
I have two actually. So one, as far as echo reports go, are there any numbers that can have kind of like inter-operator variability as far as like echo tech doing it, or are they all kind of pretty like calculated by?
So the biggest problem is that in order to measure an aortic valve area, you need to measure an LVOT area, and that is you have to measure, and it's hard to measure it accurately because the whole area is very calcified. You don't always see it so well. So when it comes to aortic valve area, there's certainly variability. So you have 3 people read it; they can do their own measurements. You're going to get some variability. Usually in the hemodynamics, the mean gradient, the peak velocity, that's less. So that is usually that's pretty set. Most people will pretty much be the same.
And my other question is, so we do a lot of the pre-ops here for people going to non-cardiac surgery. Right. So, a lot of times anesthesiologists are kind of worried when they hear a murmur or they have history of aortic stenosis. So, for those patients, what would you say should be the kind of the AS or you suspect that they have AS.
So if you have having severe yes and not having AS or not having severe yes, that changes how you're going to manage them through surgery. So that's important. So, if you hear a murmur on your, as long as it's a systolic murmur, then you should certainly get an echo to assess it. If there's a history of AS or some history of aortic valve issue that the patient told there's no previous echo here, you don't know, then I think those things are echoes. And you certainly should get it. I mean, echo is so easy and it's so quick and so simple to get so definitely for non-cardiac surgery, if you working up, get a patient ready for surgery, then no question you should do an echo. Now, what do you do with the numbers? So then it's really is it severe or not severe, right? That's kind of your divergent point. I would certainly look for that make sure you don't have significant aortic valve disease.
But to that end, if losing these people where we're seeing them in surgeries in a couple of days and they have moderate to severe AS, or Doppler and that's 1.1.
Right.
And I think it's not always clear if cardiology should see them first to and they'll be like, oh, I can pretty much get a appendicitis there.
Right. So those are tough. The question: what is the cardiologist going to do? The cardiologist not going to do anything special. I mean, we don't have any. You're not going to send him for aortic valve. So again, I guess it depends. If you think that there's a question of, I mean, you got are we going to intervene on the valve? Or we're going to delay the non-cardiac surgery, or not? That's really the question, right?
Part of the question is the stress test. Stress test.
Right. So, like I said, if you have numbers that are so something that fits in when you have patient asymptomatic, it doesn't fit in anywhere else for aortic stenosis. So if the patient has aortic stenosis by the numbers, and there's symptoms, then the stress is not going to help you. It's only going to help you if you have a patient who says they're asymptomatic. And in that case, I would say yes, it's worth to get it because then you might be unmasking a condition that needs to be dealt with first, especially if it's not urgent cardiac surgery. So that's as far as stress testing. As far as a cardiology consult, I know I feel like we don't do that much more, or we can't do that much more than you can do. Maybe we're a little more comfortable, saying, oh, your valve area of 1 is, I'm not so impressed. I will let a patient go. But I mean, that's true. That's the way I would do it. We don't have any tricks or any special tests that you can, whether the valve is yes or no. It's just a combination. We got to look at the physical. You got to look at the symptomatology and some of the parameters. Again, if you're not sure, most of the time, all it means is that they're gonna just monitor the patient a little more during surgery. Usually doesn't mean if the patient really does surgery, they're not gonna just say, okay, this patient's not a candidate. So if you're not totally comfortable with it, I guess asking for a little help is reasonable.
Along the same lines, what about asking for cardiac anesthesia versus regular anesthesia?
Right.
Is that
so
asking for significance?
So like I said, if they have severe, I think that's reasonable. So again, you gotta distinguish. If your valve area is valve area 1.1, valve area 1, I'm like, okay, that's not a huge deal. But it's because of kind of the comfort we've had with seeing these patients. So, but it's reasonable. If you want to call a cardiologist for that, I think that is not unreasonable. So the valves do very well. They generally get imaging of the valve before they leave the hospital or within two weeks or so, just to kind of get a baseline function of the valve, so we can have future reference. But otherwise, you usually see them within a few weeks to make sure everything is okay. But after that, it's once a year. It's really not. They get antiplatelets. Aspirin, Plavix, yeah, but not anticoagulation.
Because for the surgical, I think they do. Right?
Surgical, they do very briefly. For the bioprosthetic valves, it's just very brief. It's long. It's not even 6 months. Usually, we see them after we stop it, at 3 months at most. but it's not long term. But these are they never get anticoagulation. It's always antiplatelets. Okay.
Thank you.